So we can start, sir. Das sir.
स्टार्ट बट तो कहाँ गायब हो गया मैं देख रहा हूँ.
Sir, we can hear you, sir.
नहीं, you can hear me. हाँ, yes, full screen, you can hear me. Okay, ठीक है. So up to what time we will continue?
Sir, whatever you say, sir. 10:15 we can continue, sir.
10:15. Okay, it should be 1 hour ना सर कहते हैं.
Yes, yes, sir. Yes, sir.
ठीक है. वो तो कहाँ है वो?
Niranjan.
उस
Yes, sir.
निरंजन का फोटो कहाँ चला गया?
Sir, my camera is on, sir.
हाँ, keep your camera on. I need to see you. I can focus my camera because a lot of activities are going on the backdrop.
Sir, your name. I can't see, sir, in this.
वही वो ये कंप्यूटर में वो मैडम
Vijay Lakshmi
वो मैडम के नाम पे वो इनका एक कंटिन्यूअस चलता रहता है मैडम का.
Okay, sir. So I'll make you a co-host, Vijay Lakshmi, Dr. Vijay Lakshmi Nags. Okay, sir.
अरे जो भी करो तुम.
Yes, sir. We can start, sir. Now, sir. We can start.
Okay, let's start. So you are with me or who else?
Sir, Dr. Rajendra Desai is also here, sir.
Rajendra Desai, can he? I'm Dr. Das. Hello, Dr. Rajendra.
Good morning, sir. We know each other. You covered esophagus for us.
Okay.
And we had met in Jaipur Surgical Festival.
Who else? I'll be with you.
Yes, sir.
Yeah.
Rajendra sir, both of you are there, sir.
Okay.
Maybe
And
I have to leave.
you will not be there.
Sir, maybe I have to leave, sir. I am some ritual function of my
Why?
family.
No. Why I'm asking is we will do the discussion accordingly.
Yes, sir. So I may not be, but both of you will continue, sir.
So I will start or Dr. Rajendra will start?
Sir, you will start, sir. Dr. Rajendra, in between, he will comment.
Okay.
Anything.
You are the lead person, sir.
Okay. Dr. Niranjan,
Yes, sir.
please switch on your camera and start.
Yes, sir.
Yes. So how did you prepare for this case?
Sir, the patient presented to us in emergency, sir.
No. How did you prepare for this case presentation?
Sir, I used certain material, sir, like whatever, like notes, what I had, and I read some topics from V.K. Kapoor sir's book on bile duct injury.
Did you happen to read some articles?
Yes, sir.
Okay, you have read some articles. See, this is not an examination. Remember, so don't get tense or something. There has to be a free discussion. Even if you are making mistakes or I am making mistakes, I'm telling you in AIMS, we don't deal with biliary injuries too much. We only deal with very complicated biliary injuries, and that too again very rarely. I'll show you one example which I did yesterday only.
Yes, sir.
So I think your experience and knowledge would be much more than mine. Maybe theoretically, I may be a little bit better. Our surgery department does all the biliary injury part initially, mostly.
Yes,
So I will also learn from you and Rajendra. So Rajendra, do participate actively, and wherever you want, just tell.
Sure, sir. Thank you.
Okay, please present. What I will do is my format actually is every step, each slide we stop and then we discuss a little bit and move to other slide.
Yes, sir.
Okay. Okay, please start.
Yes, sir. So my patient, Mr. Bilal, is a 40-year-old male resident of Bharatpur, butcher by occupation, and history is given to me by the patient and the attendant, who is his brother.
Why the patient couldn't give history? What was the problem?
Sir, the patient could give history, but certain details like immediate post-op, whatever was counseled to the attender, and when the patient was in ICU, that part brother was able to tell better.
Okay, so my point is the patient was in a state to give you full history otherwise.
Yes, sir. Yes, sir. Patient was conscious and oriented when I took the history. Yes, sir.
So that is the part.
Yes, sir.
Any significance of this demography for your case?
Sir, he's a resident of Bharatpur, sir. So he's
I
he's
can't hear.
sir, he's belonging to a rural place, sir. So he has undergone his surgery also in a local, I mean, in that area.
Okay, so at best we can think of from this demography possibly could not have been operated in a better place, in a well equipped place,
Yes, sir.
and so that's what appears to be
Yes,
from
sir.
this presentation. Though we don't know whether he has been operated or not operated. So I
Yes,
have
sir.
gone through your slides. I know he has been operated, so nothing to hide about it.
Yes, sir.
Okay. Next slide.
Yes, sir. He came with a chief complaint of abdominal pain since 5 months. Patient underwent laparoscopic cholecystectomy, that is surgery, 1 month back. He has complaints of abdominal distension since 20 days and shortness of breath since 15 days.
So how did you know that he has undergone laparoscopic cholecystectomy?
Sir, patient leadingly gave me this information that he has undergone surgery for the removal of gallbladder with uh, uh, through Durbin. So I assume that it could be laparoscopic cholecystectomy.
What is more confirmatory? So more confirmatory would be to show him the gallbladder, isn't it? But doctor might have shown him. Did he show?
No, sir. He had like the doctor had not shown him the gallbladder or the gallstones in the post-operative period.
Okay. So after surgery, all these things happen since 20 days, shortness of breath since 15 days.
Yes, sir.
Okay. So what do you think is happening from this point?
Sir, he's having post surgery. He's having pain, abdominal distension, and shortness of breath. So I am suspecting that there could be some complication related to the surgery. Abdominal pain he's having since 5 months, but I would like to know more about the pain, how it was before surgery and after surgery, so as to draw more conclusion about what has actually happened.
What are the causes of pain after laparoscopic cholecystectomy?
Sir, after cholecystectomy, patient can have, which is most common, is he'll have surgical site pain, sir, post-surgical pain. Second thing, sir, patient, sir,
No, no, it's not some disturbance, Anan. Some
uh,
disturbance in the background.
uh, so the pain could be related to the surgery, sir. First, second thing, pain can also be because of any inadvertent complication that had occurred intraoperatively. That can also be the reason for pain.
So you have to classify in two ways. Either it is early, immediate, early or late, or and also you have to classify what is the what are the classification of pathology. So
Yes, sir.
pathology means wound related, inside related, and other thing, other probabilities other than the surgery.
Yes, sir.
That could be something else happening in the patient other than surgery.
Yes, sir. Yes, sir.
Anand, anyone listening to me, please stop the background. I can't hear. Is something happening in your background? Rajendra,
Sir, just a second.
No, sir.
oh, there is some background sound coming.
It's coming from somebody, one of the participants.
Okay, okay. So
One of the hosts has to disable any unmuted mic.
okay. Then next slide.
Done, sir.
Next slide.
Yes, sir.
I can't see your slide.
Just a second. Yeah. Sir, can you see now?
No. Ajender, can you see? Yes, we can
Yeah.
see now.
So patient
From
underwent.
this
Yes, sir.
slide, we got to know that there is some problem following the surgery. It could
Yes,
be
sir.
related to the surgery, may not
Yes,
be
sir.
related to the surgery. It could be something.
Yes,
For
sir.
example, patient might have developed peptic ulcer during this period
Yes,
or
sir.
something else. And the surgery itself could be starting from the wound, anything inside.
Yes, sir.
Okay.
Yes.
Next.
History of presenting illness. My patient's history dates 5 months back when he experienced pain in the right upper quadrant of the abdomen, which was mild to moderate in severity, colicky and intermittent in nature, precipitated with meals, non radiating, relieved with oral medication, associated with occasional nausea and non bilious vomiting.
So, what is your take from this? Forget
Uh,
about the surgery and all this.
yes,
What
sir.
is your take from this? What was happening in the patient?
Sir, patient is having right
What are
upper
the
quadrant.
differential diagnoses you would make with this type of presentation?
Sir,
You,
patient could be having biliary colic, sir, secondary to polylithiasis.
Mhm. Any other diagnosis? Nothing is possible. See,
Uh,
gallstones can be associated, asymptomatic gallstone can be associated with many diseases. It could be even colon, it could be upper GI, it could be liver, many areas in the abdomen. So you have to know whether that was actually from the gallbladder or somewhere else. Or
yes,
that's what we discussed in the previous slide.
yes,
That
sir.
that even this presentation could be the something missed that is appearing now and the gallbladder has been removed.
Yes, sir.
Okay. So from this, what is your diagnosis? You say it is gallstones.
Yes, sir.
So does colicky pain occurs in gallstones? What is the typical pain of a gallstone?
Sir, it is dull aching type of pain, sir.
It is not dull aching, typical biliary colic. Description is important. It is a continuous lancinating type pain as if something is quick, stabbing or pressing or compressing in the right upper quadrant, either in a belt-like fashion or going to the back, lasting for at least 6 to 8 hours, may or may not be associated with vomiting. That you must be able to describe. So
Yes,
it's colicky and intermittent in nature.
yes, sir.
If you are present in the case for the first time, this case in undergraduate or postgraduate level, you should not say from this presentation that the diagnosis only gallstone.
Yes, sir.
So colicky intermittent pain that could be from the colon, from the kidney, from the liver areas, peptic ulcer syndromes, so which usually uncomplicated do not present like this. So, there are many possibilities that we want to know whether actually he has been correctly operated or not.
Yes, sir.
Okay. So, this is the thing. Why biliary colic occurs?
Uh, biliary, sir, in it is due to the presence of the stones that the uh, after post meal, sir, there is a contraction of the gallbladder to push the bile. So that is the reason that like biliary colic occurs.
So, it is because of obstruction to the outflow when the gallbladder tries to contract. Unlike the small bowel, which has a rapid peristalsis, you find a colicky pain. Here, there is no peristalsis. Once gallbladder contracts, means waits till the bile is evacuated out, and that obstruction mostly is because of stones. What is? Tell me one more other cause for biliary for colic, biliary colic. So usually in biliary dyskinesia, it's another diagnosis which can occur
Yes,
even in without the presence of stone. Hmm?
yes, sir.
And stricture, any compression of the cystic doc, because of the tumors. These are rare possibilities.
Yes.
So when you are presenting a case, because you will be presenting advanced cases, much more difficult cases than a simple gallbladder stone. So you should know all this.
Yes.
Okay. Next.
For these symptoms, he was evaluated and found to have gallstone disease, for which he underwent laparoscopic surgery for removal of the gallbladder. Surgery was done on elective basis on 24th of June. That was 1 month back.
History of present illness. Anything else you want to know from here? From the patient? You need to know whether it was a so-called simple cholecystectomy or a complicated cholecystectomy.
Yes, sir. Yes, sir.
Complicated gallstone.
Yes,
So
sir.
what all are included in complicated gallstone disease?
Sir, patient will have for complicated. A patient will have a long history of
Tell
symptoms.
me
Sir.
the conditions which is
Where a
described in literature under complicated gallstones or complicated gallstone disease,
sir,
for which lap poly can be done.
sir, it can be chronic cholecystitis, sir, acute cholecystitis.
Chronic cholecystitis, any gallbladder stone you do, histopathology will be chronic cholecystitis. That is not complicated. Complicated is acute cholecystitis,
Mirizzi syndrome, sir.
localized ruptures in medically compromised persons. Those are complicated gallbladders,
Yes, sir.
thick walled gallbladders, partially embedded in the liver. So, with or without fistulations to the nearby structures. So, those are complicated gallbladders. So, at least you should take the history whether it was a acute cholecystitis or not.
Yes, sir.
So, what features would be added here if it is acute cholecystitis?
Sir, a patient would have severe pain in the right hypochondriac region associated with fever, sir.
See, I would suggest you, once you are going ahead in the ladder in MBBS, MS, and all this, hypochondriac is a psychiatric term.
Yes, sir.
Have you heard? So better use the term hypochondrium rather than hypochondriac.
Hypochondria.
Okay.
Yes, sir.
So terms you have to be careful. So that is all right. But how does it differ from a uncomplicated gallstone? What will be there in acute cholecystitis where that will not be, most probably not be with
Sir,
gallstone?
sir, fever will be there in acute cholecystitis, sir.
Maybe there the pain will be more intense
More pain will be more intense, sir.
and there will be tenderness.
Yes, sir. Tenderness will be there.
Next.
And
So
pain will be more than
till
6
now,
hours.
Rajendra, you want to ask?
Yeah.
Yes.
And pain will be for more than 6 hours, usually in acute
Acute
cholecystitis.
Yes, sir.
With 6 to 24 hours of pain, then you
Yes, sir.
diagnose acute cholecystitis.
Yes,
Less
sir.
than 6 hours, it's biliary colic.
Yes, sir.
Yeah. Another thing is complicated gallbladder stones are also associated CBD stone disease, associated acute pancreatitis.
Yes, sir.
All these conditions come under complicated gallbladder.
Yes, sir.
Frozen callus for any reason.
Eh, Yes, sir.
All these come under complicated gallstone disease. Associated diseases like recurrent pyogenic cholangitis, hepatolithiasis,
Yes.
sclerosing cholangitis. All these conditions come under
Difficult gallbladder.
complicated gallstone.
Complicated. Yes, sir.
Yeah, so we are at the level of patient presentations. So we will discuss about the complicated, ascertain the cause of complication or the nature of complication, complicated gallbladder from his history. So whether there was a problem during the surgery, you can anticipate from that. Okay. So
Yes, sir.
next. So he underwent laparoscopic cholecystectomy.
Yes, sir.
Would you have done the same thing or gone for a open?
Sir, he has. I would have had gone for same, sir. Laparoscopic surgery only, sir.
Why laparoscopic cholecystectomy is better than open?
Sir, because uh, the incision is smaller, sir. The post-operative recovery is better, and it is minimally invasive, sir. So, and it is an. I mean, I am not suspecting a very complicated gallbladder in this case because he has symptoms which are that of a biliary colic, simple biliary colic. So, I'm not suspecting a complicated gallbladder.
What are the general benefits of a laparoscopy?
Sir,
What do you mean by early recovery?
sir, patient will have a smaller scar, sir, so he will be able to ambulate earlier in the post-operative period, sir. Pain will be
Okay.
less, sir. So in general, patients,
What
uh,
else? What about ileus? What about immune system?
yes,
What
sir.
about
The inflammatory, the body's response also will be like the inflammatory response that we
all that
surgical
you have to
stress.
tell when somebody asks you the benefits of laparoscopy? You have to mention all those things.
Yes, sir.
Niranjan, at this stage, there is a very straightforward answer to this question, and you should be ready with this. That several randomized control trials followed by systematic reviews and meta-analysis have
Yes,
established the fact that laparoscopic cholecystectomy is better than open cholecystectomy in factors or reasons or findings. So that the hospital stay, return to activity, better bowel functions, uh, the appearance, no,
yes, sir.
and less complications, which was there earlier and was not there. You said that it is not complicated. That's why I will go for laparoscopic cholecystectomy. Have you read any article which addresses the role of laparoscopic cholecystectomy in any randomized trial, complicated, the complicated which we discussed, complicated gallstones. See,
For
it has
acute
been very there.
cholecystitis, Niranjan, for acute
Yes, sir.
cholecystitis, is
Yes, sir.
laparoscopic cholecystectomy better or open cholecystectomy better?
Sir, laparoscopic cholecystectomy is only
There is a
better.
trial for this, which has shown benefit in acute cholecystitis. For how many days you can do a laparoscopic cholecystectomy?
Up to 72 hours you can do, sir, laparoscopic cholecystectomy.
No, 5 to 7 days.
So, Niranjan, there is a very good article that has been published in January 2025. That is a randomized trial of 300 patients comparing the outcome of laparoscopy versus open cholecystectomy, particularly in difficult gallstones, the difficulty which we discussed. So,
Yes,
and it has shown that the advantage over open cholecystectomy is nearly double. Though I don't agree with that article in all the aspects, not a really a lot of biases are there, but it is a randomized trials published. And there are also other trials which says that even in these situations, lab cooling could be better than that. Okay. So yes, so he has done that. What happened then?
sir, I have asked the details of the surgery. Surgery was surgery lasted for 2.5 hours. At the end of surgery, relatives were briefed that the surgery was difficult. A drain tube was placed in the abdomen in the post-operative period. No blood transfusion was given intraoperatively, and patient was immediately shifted to the ward in the post-operative period.
Anything else, Aj, if you are the operating surgeon or the referred surgeon, not the primary surgeon,
Yes, sir.
anything else you would ask? What are the points you should ask?
Sir, I would like,
Apart from what you have asked, anything you missed?
sir, was there any bile which was seen intraoperatively? Was there any major vascular injury that was encountered? Intraoperative blood loss? Was the frozen, I mean, was the calyx frozen or it was a simple cholecystectomy? And the gallbladder, sir, I would also like to ask about the gallbladder. Was it a thick walled gallbladder or a normal gallbladder?
So this is again a straightforward question. The answer has to be very clear, starting from the entering into the abdomen, starting from the port side. Any problem happened during port insertion? Then what were the findings? And then what was the critical view of safety established, not established, and
Yes,
whether adhesions and whether difficulty, blood loss, identification of structures, whether intraoperative cholangiogram was done, what would
yes, sir.
be duration, and finally, whether the gallbladder was open, seen or not, or whether it has been sent for histopathology or not.
Yes, sir.
And
Yes,
then
sir.
the last question you have to ask, these are all I am telling from guidelines.
Yes, sir.
So if I am asking you, what are the two guidelines that you should mention that I have followed this one? Tell me two guidelines.
Sir, critical view of safety guidelines.
Guidelines for safe laparoscopic cholecystectomy or bile duct injuries. So one guideline is World Society of Emergency Surgery. That's a very good one. There's a 2021 and our own Indian guidelines. That's 2016. If you read these two, there's almost everything in that.
Yes, sir.
Okay. So you must have that handy for your examination and practice both.
Yes, sir.
So you asked all these things. Rajendra, anything? Dr. Rajendra? Okay. Now next one.
Yes, sir.
Hmm.
On the next day of surgery, patient had pain in the right upper quadrant of the
No,
abdomen.
nothing, sir.
Ah,
You can continue.
okay.
Pain was dull aching type, continuous, non-radiating, moderate to severe in intensity, and it required IV medication.
What was the cause?
Sir, post,
Why this type of pain would occur on day one?
sir, I'm suspecting some kind of uh, sir, it can be because of some collection in the right hypochondriac region, right hypochondrium.
So you suspect collection, straightway collection. It could be, I told you just now, it could be wound, there could be wound
Sir.
hematomas,
Yes, sir.
there could be
What is your
collection in
opinion
that.
about a drain, Niranjan? What is the utility of a drain in detecting bile leak?
Sir,
Will it
if
detect all bile leaks?
no, sir, not all bile, like only in case that where there is a lateral injury or where there is cystic duct leak, bile will freely flow into the drain.
Here, patient has said symptoms have started 10 days subsequent to the surgery. That means
No,
after discharge. So, what is your differential diagnosis?
sir, patient had pain immediately next day after surgery, sir.
So
Pain is not enough, no? Pain can be post-operative pain.
Yes, sir. Yes, sir.
He didn't have distension, he didn't have fever, he didn't have jaundice.
Yes,
So
sir.
why did you suspect any problem with the cholecystectomy? Don't go by retrospectoscopic diagnosis. This is something that is starting later.
Yes, sir.
So your differential diagnosis will necessarily be different.
so
Early,
that question I
delayed
asked,
are different.
that's why from the at this point I asked you, so what are the possibilities? So you should know all the common possibilities, and last you should say about that there is a collection or something, just
Yes.
from the presence of the pain. That's what he is saying.
Yes, sir. Yes, sir.
Okay, so up to this point, there could be few more questions. I'll just run through the questions. See, you said 2.5 hours. Is it normal or not normal? Then you'll be asked question, what is the normal timing of a lab coolie in an uneventful situation?
Yes, sir.
What is that?
Sir, it is around 1.5 hours, sir.
So it is 30 to 90 minutes,
90 minutes.
according
Yes.
to the literature, not on your own. So
Yes, sir.
more
Yes,
than
sir.
anything, more than that is a prolonged surgery.
Prolonged surgery. Yes,
So
sir.
you should know what is the cause. Then you should know what are the questions to the surgeon, including whether there was leak or spill. And you should ask about the indications of the drain. Would you put a drain? What are the indications of putting a drain in a lab cooling? What are the indications?
Sir, if there was like intraoperative spillage of bile, or in case where there was any vascular injury or excessive bleeding, we'll put a drain, sir.
So if
Also,
there is suspicion of biliary injury
injury.
or there was bile leak, there was significant spill, inflammation was there, and if there was bleed, and of course, finally must say it is surgeon's discretion.
Yes,
He
sir.
wants to sleep well at night. That's all.
Yes. Yes,
So
sir.
in those cases, you put a drain. He has put a drain, and you might be asked, why did you ask for transfusion? You thought of biliary vascular injuries, no?
Yes, sir.
What? How the vascular injury is classified? That would be asked. I will cross over this because of lack of time. So there are major vascular injuries, there are minor vascular injuries. You
Yes,
should
sir.
know what is called major, what is minor. Mesenteric vessel, minor or major?
Major, sir.
No. So that's what I'm saying. See, mesenteric vessel doesn't mean that SMA injury. So
Okay.
omental
Mental
vessels,
vessels.
mesenteric vessels, epigastric vessels, they are minor injuries.
Minor injury. Yes.
Aorta, IVC, iliac, right hepatic artery, portal vein,
Common.
or the major
Portal.
injuries. And
Yes, sir.
then you should know what are the types of injury, like for trocar injury, dissection injuries, clip slippage, all this. So that's a separate chapter altogether.
Yes,
Okay.
sir.
So he had next day pain, and it was like that, and it was corrected by medication. Next.
The drain output in the immediate post-operative period was around 5 to 10 ml, and it was yellowish in color. By post-operative day 3, the drain output was nil and it was removed. Intensity of the pain had reduced and patient was discharged on post-operative day 3.
What was happening? Why do you think that stopped?
Sir, maybe the drain could have, I mean, there is a possibility that the drain output had the yellowish fluid that was coming in the drain was just spilled bile, which came till post-operative day 2.
Yes.
Another reason could be that the drain stopped because the drain placement, I mean, the drain was not draining the collection proper. The drain tip was lying elsewhere, or it could have had been kinked or blocked as well.
So blocked drain, misplaced drain, leftover fluid, or it
Yes,
could be injury itself,
yes,
which
sir.
has temporarily sealed off,
Yes,
or
sir.
any other injury that has opened up later on if it
Yes,
has to, and this injury has stopped. There might be
yes,
another injury to follow, but these are stopped.
yes, sir.
Okay. Then next, at this stage, would you discharge the patient or not?
Yes, sir. Because the drain output has reduced, the pain also had reduced. Patient was tolerating diet. That there was no fever, no tachycardia. So I would have had discharged the patient.
So at this
I
point
would
of
have had
time,
done a repeat. I would have had done a repeat ultrasound to just check if
yeah,
the
in the
UVI score is correct.
now in this scenario, the guidelines say that at least you have a blood investigation and a baseline ultrasound to say what was happening later on. Okay,
Yes.
next slide.
Patient had ongoing episodes of pain and progressive abdominal distension with nausea and vomiting once he was discharged home. He also had episodes of fever which were intermittent with associated with chills and rigor, and they were relieved on oral medication.
Dr. Rajendra,
Yes, sir.
You please ask questions.
I will. At the moment, I don't have anything. Let him
Okay.
continue, sir.
So, what was happening? What was your thinking? What is happening?
Sir, the pain had reduced till day 3, like when he
No,
was discharged.
with this presentation, what is your diagnosis at this point?
Sir, it can be some injury, biliary. I mean, it can be some injury to the bile duct, sir. It
The
can be
injury will not cause fever. Injury will not cause pain directly. Something has to be there to cause this problem.
yes, sir. There
What?
could have.
What are the causes of cystic duct blowout, Niranjan?
Sir, cystic duct blowout can occur because of improper application of clips, sir. There can be there can be residual stone in the CBD, sir, choledocholithiasis, which can
Yeah.
cause back
So,
fracture and
is
blowout.
that a cause for pain? Choledocholithiasis, can it be a cause for
Yes,
pain
sir.
and
Yes, sir. Yes, sir. It
uh,
can cause
discomfort?
pain. Yes, sir. Yes, sir. It can cause.
How is the pain of choledocholithiasis different from the pain of gallbladder stone?
Sir, choledocholithiasis will have associated colicky pain will be there, sir, in choledocholithiasis.
No, it is similar.
It
Similar
will.
symptoms will be there in choledocholithiasis as compared to gallstone disease, but the pain will be more intense. It will be epigastric, radiating to the central back,
Yes, sir.
especially if the stone is impacted at the lower end.
Yes, sir. Yes, sir.
Next slide.
The patient was readmitted after 2 weeks in view of above complaints to another hospital. There he underwent an ultrasound which showed intra-abdominal collection as it was explained to the attenders, for which patient was operated on the same day and laparoscopic drain placement was done.
What is your comment on this? You would have
Sir,
done. You would have done this thing.
no, sir. Actually, I would have had gone for ultrasound guided drain placement if there was any intra-abdominal collection.
What else? In which condition can straightway move after the ultrasound for surgery?
Sir, in case if there would have had been other associated injury like a duodenal injury or a colonic perforation which was suspected, I would.
That is all right. What? Peritonitis.
Peritonitis, yes, sir.
Frank, generalized peritonitis is there. Intra-abdominal collection may or may not be there. That is one indication where you straightway go into the laparoscopy or open whichever you are comfortable.
Yes,
So,
sir.
what is the recommendation in this situation? Do a ultrasound, see for the collections. If they are there, go for a drainage
Yes, sir.
or replace the drain to the
Yes.
collection site. So, and then go for endoscopic measures if there is an injury. So that is the recommendation at present in this situation.
Yes, sir.
They went for a laparoscopic exploration. So they
Yes.
did. Then what happened? They put a drain. What is the ideal site to put a drain in case of biliary injury?
Sir, we have to keep it at the subhepatic region, sir.
Subhepatic, as close to the
As
bile site as possible.
yes, sir.
Next.
Will you put it vertically straight down or will you put it from the side?
Uh, Sir, I'll put it in the side, sir.
You have to put it vertically straight down because that will come in the incision and your exploration will proceed accordingly. You can trace the track directly. That is the shortest route, and you have to take the shortest route to the bile duct. Laterally, colon and duodenum will be there. Colon will be plastered to the abdominal wall, especially in collections, unless the collection has pushed it out of the way. So you should never go laterally. You will injure the colon. Hepatic flexion.
Okay, what happened then?
Sir, after the drain was placed, it was draining golden yellow fluid. Patient was managed in the ICU for 5 days with daily drainage of greenish fluid in the drain around 500 ml per day on the right side and around 150 ml on the left side. Drain output subsequently came down to 250 ml per day on the right side and 80 ml on the left side. Patient was referred to our hospital with 2 drains in situ in view of persistent fever and abdominal pain.
What is the implication of this? Now answer me first. What is this golden yellow? From where the bile was coming?
Sir, a golden yellow bile indicates that it was a hepatic bile, sir.
And gallbladder bile is?
Gallbladder bile is greenish in color, sir.
Duodenal bile?
Duodenal bile is dark green in color, sir.
Is it? Duodenal bile is more diluted because of the duodenal secretions, rich in bicarbonate. It is more alkaline.
More
Put a,
alkaline.
put a litmus paper, you'll know the difference. It's about 8.5, 8.6 pH,
Yes.
and it is about 7 point something. The bile pH is slightly alkaline.
Yes.
And it could be mixed with mucus.
Yes,
Could
sir.
be mixed with some food material.
Food particles.
Okay,
Yes.
so why that is yellow, this is green? Any change in content?
Sir, so there is high chloride and high bicarbonate
No,
content.
what gives golden yellow color to liver bile and darker to gallbladder bile? Chemical. Bilirubin.
Yes, sir.
So golden yellow rich in bilirubin. This is rich in
Sir, the bilirubin concentration is
bilirubin,
more
and gallbladder bile is rich in biliverdin.
biliverdin. Yes, sir.
So why it was 500 ml, then it dropped down to 250 ml?
There can again, sir, there can be same whether the drainage was like adequately happening or no. I mean, if there could have been inadequate drainage, that could result to
Suppose the drainage is adequate, because 250 ml is also not less.
yes,
So
sir.
drainage is adequate. What could be the possible cause?
So there can be a lateral injury, sir, or there can be cystic duct. The leak can be from cystic duct with there is some part of biliary continuity, is what I mean to say.
So might be in the recovery process.
Yes, sir.
Number
Yes,
one.
sir.
Number two, it could be initially associated with fluids, abdominal free fluid, and
Yes,
that
sir.
finally with nutrition and all this,
Yes,
that
sir.
is coming down and it's coming to its own volume. So how
Yes,
do
sir.
you know that it is mixed with free fluid or it's a frank bile? So do
And fever
ATM.
and abdominal pain associated with golden yellow bile. What is the contradiction here?
Uh,
Does it agree with one diagnosis or it disagrees with one diagnosis?
Sir, cholangitis. I mean,
In cholangitis, what will be the color of bile and why?
sir, it will be slightly turbid, sir, because of superadded bacterial infection.
And what color?
It will be turbid and it will be brownish,
It will be
muddy,
greenish yellow
greenish yellow.
because it will be greenish because of reduction of the deconjugation of the bilirubin and
Yes, sir.
reduction of the bilirubin to biliverdin by the bacteria.
Yes,
They
sir.
will deconjugate the bile
Bilirubin.
salt.
Yeah,
Everything
bile.
will be deconjugated. So there will be turbidity because of the infection, and they began the pus, and there will be greenish color because of deconjugation.
Yes, sir.
And what possibilities come to mind with abdominal pain and fever in a patient with biliary injury?
Abdominal pain and fever can indicate again, sir, to collect towards peritonitis, and the reason for that could be like dissemination of the bile, which causes peritonitis.
What else?
It can be due to a localized collection as well, sir. Which
Collections
is
you have told. Other than collections, what else? Liver abscesses,
Liver abscess.
cholangitis,
Cholangitis abscess. Yes, sir.
drain complications. Drains have been there for so many days. So drain complications.
Yes, sir.
What are drain complications?
Sir, it can erode into the bowel, sir. It can cause an
What are the symptoms of erosion into the bowel of a drain?
sir.
What will be the typical history?
Sir, patient will complain of sharp pain at the drain site, along with fecal material or fecal material coming through the drain, sir.
Preceded by a slight bloody stain in the drain
Blood, yes, sir.
as it erodes through the wall.
Yes, sir.
And blood may or may not be there along with fecal material.
Material, yes, sir.
Plague.
So these are the possibilities. Okay, go on.
Uh,
There is no history of similar complaints in the past, no history of yellowish discoloration of eyes, no history of easy bruisability, ecchymosis, or petechiae, no history of reduced urine output, no history of bone pain or muscle weakness, no history of hematemesis, melena, or altered sensorium, no history of loss of weight and loss of appetite.
why all these things are so important in this case? So
Sir,
similar complaint in the past means what?
Sir, I want to rule out whether a patient has had chronic cholecystitis or a long-standing gallbladder disease.
The chronic cholecystitis will have abdominal pain, fever, distension, all these things.
No, sir, just the pain, sir.
It should be just not for just for the sake of presentation, it should not include. So the main aim of presentation is all your presentation should point towards a diagnosis, logical
Yes.
conclusion hona chahiye. For
Yes.
example, you have written easy bruisability. Yes, yellowish discoloration, fine, whether he had in liver problem or not. But easy bruisability now at this stage, why it should be?
Sir, it can be because of vitamin K deficiency, because the bile, the bile is not there, so there is no.
No, why past history of this is important? Yes, the answer is yes, but you should
Yes.
know why. Because these are anticipated factors for difficult cholecystectomy and bleeding and prolonged surgery, whether they were there or not there. And past history of reduced urine output, I'm skipping over, I'm not discussing all these things. So you should be very careful in presenting how it is related to this one. Okay, next. History, loss of weight, loss of appetite. There could be many things you can ask in the past, but how they are related to this particular abdominal problem, which we anticipate that it is a post-lap coli problem. Next.
There is no previous history of diabetes,
And
hypertension,
you must know how diabetes and hypertension is important for making the lap coli difficult. Okay, next.
personal history. Appetite is reduced. It was normal before the surgery. Bowel habits are altered. Intermittent episodes of constipation with abdominal distension is patient complaints of intermittent episodes of constipation with passage of stools on enema, and they were regular before surgery. He's a non-smoker and non-alcoholic, and family history is not
Again,
contributed.
you should obviously question will be why altered bowel habit, why constipation, diarrhea, like that. But what is more important, you should ask, we have mentioned here, is the color of the stool. That is more important than
Yes,
this.
sir.
Next,
Yes.
you say
You have not said passage of flatus. Is he passing flatus?
Yes, sir. Currently, he's passing flatus, sir.
Okay. What is the difference between flatus and stools as far as peristalsis is concerned?
okay. Tell the answer.
Uh,
No, Rajendra, tell the answer.
Yeah, flatus requires active peristalsis, while stools doesn't require active peristalsis. Loose stools can be passed without active peristalsis, passively by weight of stools, while flatus requires active peristalsis. Therefore, in any case of peritonitis, they may still pass loose small quantities of stools in pelvic abscess they'll pass small quantities of mucus, but that doesn't mean they are passing. They are having normal peristalsis.
Yes.
And see, family history, the natural question would be which family history is important for laparoscopic cholecystitis. So, for example, you have to say that yes, history of bleeding, history of liver disease, history of anesthesia problem. Do you know what are the two most important complications of lap chole? The number one is anesthesia problem. The number two is what are the complications? Biliary problem that you had, the wound problem, the biliary problem. So there are five in order which you should know. So similarly, family histories, if you are mentioning, you must know the answer. Next.
Sir,
That we have discussed. Then
yes, sir. Summary: my patient is a 40-year-old male with no comorbid illness. He underwent a difficult
we have gone through all this detail. Now, what is
Yes.
your diagnosis?
Uh,
Next slide would be your diagnosis.
yes, sir. Sir, my probable diagnosis is sepsis secondary to bile duct injury, status post laparoscopic cholecystectomy, treated with laparoscopic lavage and drain placement.
So I would say that there are two groups of diagnosis which can be here. One diagnosis related to the collection inside the abdomen, and one is problem inside the bile duct. That is cholangitis. So how do you differentiate between the collection related pain, fever, and jaundice versus bile duct problem, pain, fever, and jaundice?
Sir, related to the collection, patient will have sir, there will be patient will have pain, which will be in the right hypochondrium region.
That will be both. That will be all these three will happen in both. So only one thing, all these three things will happen in both the situations. So and also tenderness. Well, only thing is that the difference is really not very significant or very well demarcated. But in one condition, the jaundice would be rare and appears later than the other conditions. Where jaundice will come earlier,
Sir, in case of
cholangitis or collection.
jaundice will come earlier in cholangitis, sir.
And what are the causes of jaundice in collection?
Sir, it can be because of the peritoneal absorption of the bile.
Very, 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 very rare. Commonest is compression.
Compression of the bile duct.
Do all collections cause pain, fever, and jaundice?
No, sir, not all collections. If it is a well localized and a small collection, it may not cause symptoms.
Is the bile normally infected?
No, sir. Bile is sterile normally.
Bile is sterile. So in obstruction, what is the presence of bacteria? Incidence 85%. So when it is a huge collection or it is infected or there's some sign of peritonitis, then only they become
Secondarily.
symptomatic, or they could be just a sterile bilioma. Okay, so these are the two groups now we are narrowed down. Rajendra, any question? Then go over to the next.
Next slide, please.
General physical examination. My patient is a young gentleman who is averagely built and nourished. He is dehydrated and he is lying in the bed. His height is 160 centimeters, weight is 78 kgs, and BMI is 23.5 kg per meter square. His pulse is 118 beats per minute. BP is 100 by 60 millimeters of mercury. SpO2 is 92% on room air and respiratory rate is 26 cycles per minute. He is currently febrile with a temperature of 101.3 degrees Fahrenheit. Pallor is present, there is no icterus, bilateral pedal edema is there, and there are no peripheral signs of chronic liver disease.
What does it say?
Sir, currently a patient's dehydration and tachycardia can be attributed to the ongoing sepsis that he has. Along with that,
So there's some feature of sepsis you are hinting at because of tachycardia, maybe and tachypnea and high fever is there.
yes, sir.
There is pallor, there is no icterus.
Yes, sir.
Okay. So there are no peripheral signs of chronic liver disease. Do you think that after laparoscopy, the doctor hasn't spotted the nature or the appearance of the liver? So very unusual that after doing a laparoscopy, you find something cirrhosis now, which was not there. So these are the general physical examination from which we think possibly he has an element of sepsis
Yes, sir.
and possibly no cholangitis.
Yes, sir.
Next. Yes.
On inspection, abdomen is distended. All quadrants move equally with respiration. Post-operative scars are present over the anterior abdominal wall. Two drains are present, one in right hypochondriac region and one in left iliac fossa. There is no evidence of erythema around the drain site. Scars of the standard laparoscopic port placement are seen. Scars are well healed with no cuff impulse over the scars. Umbilicus is central and inverted. There is no visible impulse, sinus, engorged veins or pulsations or cuff impulse. Inspection of the groin hernial sites reveal no swelling or cuff impulse. Inspection of the external genitalia is unremarkable, and renal angles reveal no fullness.
So, what are the implications of this?
Sir,
Anything positive? What to your diagnosis? I don't think so. So, anything additional, if you could have found out, that might have helped you in additional diagnosis also. Okay. And while saying about BMIs and other things, the questions would be how they affect the outcomes in a major surgery that you should know. For example, obesity, how does it affect, Next.
on palpation, mild abdominal distension is present. There is no tenderness, no organomegaly present, no tenderness, bogginess, induration, or cuff impulse present over the scar marks. No evidence of discharge or collection at the drain site. Groin hernial sites and external genitalia are normal.
But do you think it gels with your the history or observation, the finding which you are getting on palpation? See, the patient has, you think, sepsis, and obviously it is coming from the abdomen side.
Yes, sir.
And natural question would be how come there is a very silent and no problem abdomen on palpation, but patient has sepsis? So this is actually out of proportion. Maybe you are correct. We have to see later on what is how does it correlate with that history or so. Okay.
Yes, sir. Yes.
Percussion, what did you find?
On percussion, upper.
So at least from the palpation, we say possible there is no tenderness, no infection signs inside, or no peritonitis. Possible.
Yes, sir.
But we have to remember that this guy has fever, 102.
Yes,
so
sir.
in a normal situation, we would have thought of somewhere else the fever is coming because the laparoscopy can have respiratory complications also.
Yes, sir.
So that could be a possibility, or even the things have been actually masked by the analgesics and antibiotics,
Yes,
which
sir. Yes, sir.
not a good
Yes.
one. Percussion, what did you do? And what did you find? Just tell us the main findings.
Sir, percussion essentially was normal, sir. The abdomen was also tympanic to percuss. There was no evidence of free fluid. On auscultation, normal bowel sounds are heard. There is no bruit, venous hum or rub.
Anything it adds to your findings?
No, sir.
So maybe there is no obvious fluid which you could found out. and obviously the tenderness is not elicited by percussion. Had it been, it would have been difficult to do a percussion at all. Okay, next.
Rectal examination is unremarkable and the gloved finger is stained with normal colored stool.
What you expected from here? That do you did a PR thinking what?
Sir, he had episodes of intermittent constipation, sir. So I just wanted to rule out whether patient has any kind of frank obstruction or no. Or also if there is a drain in the left iliac fossa, sir. So if there is any collection which can be
That is that the drain is draining.
yes,
So yes, you wanted to know whether there has leftover stool, hard stool inside, additional findings like hemorrhoids or so, like fissures are there or not. That would post-operatively also say whether his bowel is not moving because of that. And what about a Blummer self deposit? Is it possible in this patient?
tumor cell deposit. No,
Ah,
uh, no, sir.
so had it been a incidental CAGB, is it possible?
It is possible, sir. Like I cannot entirely rule out the possibility of
When
C.
does the incidental CAGB disseminate? What is the time period?
Sir, the T stage is what you mean to ask, sir. At what
No,
T?
when does it disseminate? Suppose I found a incidental CAGB, I'm not treating it. When I will find dissemination? So one is it depends upon the stage of the disease, whether the tumor plane has been breached or not, aggressive nature of the disease,
Yes,
whether it
sir.
was actually disseminated by that time. So in those cases, the time duration depends upon that. It could be from months or 1.5 months critically, or 2 months to even in some people months or years. So that's seen, and whether there is some bleeding, you can find. Next.
Respiratory system on auscultation.
Give it next, then you have seen there.
Yes, sir. Summarizing, my patient is a young male with no comorbid illness.
We have summarized. What is the diagnosis?
Sir, my diagnosis is sepsis secondary to bile duct injury, status post lap cholecystectomy, treated with drain placement, sir, laparoscopic drain placement.
So when the drain is draining well, why the patient is having sepsis?
Sir, I have to rule out that, sir, first, whether there is any residual collection or any kind of localized collection which is not being drained, leading to all these symptoms. Second, also patient has shortness of breath and reduced basal breath sound. So I would like to attribute it to some respiratory causes also. That could also be the
But,
reason
but,
for.
but he doesn't have any added respiratory sounds or abnormal sounds.
Yes,
So
sir.
it
He
could be
doesn't have
just
any.
because of the pain he's having tachypnea or fever. That also can cause that one. But you don't have any objective finding of
Fine.
respiratory problem from your examination.
Yes, sir.
What should you do now?
Sir, I would like to investigate this patient first, sir. First, I would like to, like, patient is dehydrated, sir. So I would like to resuscitate him. I would like to resuscitate him first and get
Sir, it's
this.
10:20.
So I think Rajendra, we would stop at this stage. Maybe at a second stage, you can take over the second part
I think we should do that, sir.
because the clinical part almost we have covered, because
Yeah,
investigation and treatment is itself a separate
topic.
Yes,
discussion.
Talk to
And
Dr. Anand Niranjan and let him know.
yes, sir.
and he'll give you an opportunity to present or discuss this situation.
Maybe you can ask Anand to do it tomorrow, day after tomorrow, as a continuation of this.
Yes, sir.
So that would complete, because investigation and decision making for treatment is very, very important.
Important. Yes, sir.
And these are the usual questions you will have there will be a case of bile duct injury in your examination, all these things. And if it happens to be a first case, this will be the exact way how you will be asked questions.
Yes, sir. Yes, sir.
So I deliberately wanted to discuss from A to Z so far as the clinical aspect is concerned. Otherwise, you can skip a lot of things and finish it up as a second or third case. So when you go
Yes.
for a second case or a third case, they will ask you summarize the case, and
Yes.
then they go over to the investigation and treatment.
Yes, sir.
Okay, so we will discuss that if we find time, anytime in a second session.
I'll talk to Anand sir once for a slot.
Okay, Rajendra.
Yeah, thank you, sir.
Okay,
Thank you, sir.
thank you very
It
much,
was a great discussion.
Rajendra. Good insights, and this is a very interesting topic to discuss, of course.
Yes, sir.
Lots
Yes.
of things can be discussed.
I wish we could have continued, but it's difficult. We have
No,
commitment.
it's right. See, if we have 2 or 3 cases discussed in this forum, then maybe the third or fourth case, when it is presented, we can finish up everything with salient points in a single go, in a single case discussion.
Yeah, that's true.
Okay,
Okay,
thank
sir.
you.
Good morning,
sir.
sir. Yeah.
Thank you, sir. Good morning, sir.
Yeah.
Good day, sir.
Thank you, Niranjan. Good day.
Thank you, sir. Thank you. Good day, sir.